Hello and welcome to Chapter 13 in Computers in Healthcare. We're going to be discussing security, and a lot of the information in this chapter is going to be a review of health records from last semester. So a lot of these terms, once we get in here, are going to be very familiar to you. We're going to start in the text on page 218, talking about data classification. The security of health information has always been a priority of health information management professionals, but it was raised to a new level of importance with the implementation of information systems that document and retain health record information, as well as other data that can identify the patient. Data can be classified in a number of ways. One way is to classify data according to the type of data, whether it's clinical, administrative, financial, and so on. Data can also be classified into categories according to the level of security required. Different terms might be used, but one example is PHI, sensitive, and public. Who has access and how the information is used will be controlled by the classification allocated to it. With the paper record, access was limited to the record itself. With the electronic health record and other information systems, access is available from anywhere, including outside the healthcare facility. Historically, security regulations were enacted at the state level, which led to a patchwork of very different laws across the country with no consistency among them. There were and are accreditation standards and the Medicare conditions of participation that address security, but these standards applied solely to accredited facilities and facilities that treat Medicare patients, respectively. Accreditation standards generally include broad security requirements that may vary by accrediting organization. Because of security concerns of healthcare professionals and patients alike, federal laws were enacted. So our first federal law we're going to talk about is HIPAA. The Health Insurance Portability and Accountability Act of 1996 is a federal law that impacts many areas of healthcare, including insurance portability, code sets, privacy, security, electronic data interchange, EDI, and national identifier standards. HIPAA is divided into 5 titles or sections. This chapter is going to address Title II, Fraud and Abuse and Administrative Simplification. The purpose of the Administrative Simplification title is to improve the efficiency and effectiveness of the business processes of healthcare by standardizing the EDI of administrative and financial transactions. This title was also designed to protect the privacy and security of PHI, protected health information, that is transmitted from one point to another. To be subject to HIPAA, an organization must meet the definition of a covered entity. A covered entity is a health plan, healthcare clearinghouse, or healthcare provider that transmits any health information in electronic form from one of the covered transactions. A health plan pays for the healthcare provided to the individuals under the plan. These plans include medical, dental, vision, and other forms of health plans. Healthcare providers include hospitals, physician offices, long-term care facilities, ambulatory surgery centers, pharmacies, and other patient care providers. And a healthcare clearinghouse collects billing data and processes it for the healthcare provider. The covered transactions that HIPAA addresses are health plan premium payments, enrollment or disenrollment of a health plan, eligibility, referral certification and authorization, claims, payment and remitted advice, claim status, coordination of benefits, health claims attachment, and first report of injury. Health plans, healthcare clearinghouses, and healthcare providers that do not share patient information for one of these transactions are not covered entities and therefore are not subject to HIPAA. All right, dropping down to transactions and code sets. So the transaction and code sets rule were designed to standardize transactions performed by the covered entities. These standards apply to electronic transactions only, such as claim submission, eligibility queries, and many more insurance-related functions. However, paper submissions are similar. The Department of Health and Human Services has assigned the responsibility of developing and maintaining standards for the Transaction and Code Sets rule to 6 organizations called Designated Standard Maintenance Organizations. These are our DSMOs. And these 6 are listed below. We have our Accredited Standards Committee, X12, Dental Contact Committee of the American Dental Association, Health Level 7, National Council for Prescription Drug Programs, National Uniform Billing Committee, and National Uniform Claim Committee. The Transaction and Code Set standards cover individual elements and the format of the data for the claim submissions and other functions mentioned earlier in the chapter. The standards enable the use of electronic data interchange, the transfer of data from one point to another without human intervention, which can significantly improve the efficiency of healthcare. The HIPAA Transaction and Code Set requirements use ASC X12 standards. These ASC X12 standards mandate the data to be submitted, formatting and other attributes of the healthcare claims and other financial transactions. Dropping down a paragraph. Designated code sets are also a part of the HIPAA Transaction and Code Set rule. HIPAA defines a code set as a set of codes used to encode data elements. These codes record medical diagnoses, procedures, drugs, dental procedures, and other data elements. A code replaces larger pieces of data. For example, an ICD-10 code of I-10 means essential or primary hypertension. HIPAA mandates the use of certain coding systems in the reporting of diagnosis, procedures, drugs, and more on the mental and dental claims. And then you have these standards. So we're talking about ICD-10 ICD-10 CPT-4, HCPCS, the Code on Dental Procedures and Nomenclature, or CDT-2, and our national drug codes. All right, moving down to the privacy rule. The HIPAA privacy rule controls how covered entities defined earlier in the chapter may use PHI. Business associates are individuals or organizations that perform work on behalf of the covered entity and that require access to PHI. Examples of functions that business associates may perform are coding, release of information, and billing. Business associates are subject to HIPAA. HIPAA lists the specific data elements that determine whether or not information is PHI. If the information includes any of the data elements in Figure 13.1, it is considered PHI and is therefore subject to the HIPAA privacy rule. I'm not going to read all of these, but some of the examples are the patient's name, their postal address, other than town or city, state, and zip, telephone numbers, fax numbers, email addresses, social security numbers, their license numbers, vehicle identifiers and serial numbers, including the license plate numbers, any biometric identifiers, and any photographs that you may take of that patient. The privacy rule also lists the following PHI-related rights. The patient must be provided a notice of privacy practices that defines how PHI is used in the covered entity. The patient has a right to inspect, copy, and receive a copy of the medical record. The patient has the right to request an amendment to the health information. Patient has the right to request communications from the covered entity through alternative means such as a post office box rather than the home address. Patient has the right to report violations of the HIPAA privacy rule. And the patient has the right to request restrictions on how his or her PHI is utilized by the covered entity. This covered entity must have policies in place to allow a patient to claim these rights. Policies and procedures are important to the privacy rule compliance program since the rule focuses on processes and the people who develop and follow them rather than on technology. All right, so now we're moving to the security rule. So we're going to get to the technology side. Security has 2 definitions that focus on different aspects of security. The first one, the means to control access and protect information from accidental or intentional disclosure to unauthorized persons and from unauthorized alteration, destruction, or loss. And our second definition is the physical protection of facilities and equipment from theft, damage, or unauthorized access. Collectively, the policies, procedures, and safeguards designed to protect the confidentiality of information, maintain the integrity and availability of the information system, and control access to content of these systems. A covered entity must address all of the aspects included in these definitions as they are included in the security rule. The security rule defines the minimum that a covered entity must do to protect electronic protected health information, or EPHI. This is the PHI that's created, received, or transmitted electronically by covered entities. The security rule does not apply to PHI in any other media such as paper, oral communication, and microfilm. EPHI can be communicated over the internet, or it can be stored electronically such as on a magnetic drive, voicemail, fax, copy machines, such as on a magnetic drive. New sentence. Voicemail, fax, and copy machines are not considered to be EPHI. The security rule was developed to be technology neutral and scalable. Technology changes so fast that the security rule would need constant revision if specific technologies were mandated. Therefore, the rule mandates what needs to be done, but not how to do it. So the example is the HIPAA security rule mandates that physical access to electronic information systems is limited to authorized staff. It doesn't tell them how that information should be limited, how it's to be implemented. So the CE can use key cards, they could use personal identification numbers, keys, biometrics, or other means. Scalable means that the Department of Health and Human Services allows covered entities to consider the size, complexity, and capabilities of the covered entity when developing their compliance strategy. So your strategies are going to be different from a 1,000 bed hospital than if you only had a 60 bed hospital. So that's our scalable. All right, moving on to ARRA, the American Recovery and Reinvestment Act of 2009. So this act introduced new requirements related to security, which includes certification of EHRs, HIPAA audits, increased severity of penalties, and business associates subject to privacy and security regulations. In order to become a certified EHR, the software must meet specific security standards. Vendors apply to have their EHR applications reviewed by one of the Office of National Coordinator for HIT authorization certification bodies and accredited testing laboratories. That's a mouthful. The benefit to becoming certified is that qualified healthcare providers are able to obtain incentive funds for the use of the EHR in a meaningful way. So again, that goes back to meaningful use. All right, so moving on to the next section. Getting into more of the security pieces of this. And this will be some of the things that you should remember from health records. Threats are potential for the vulnerability to be exploited. And vulnerabilities are weaknesses that could be exploited, thus creating a breach of security. Threats come from internal and external sources. Internal threats come from employees, hardware factors, and the environment. There are 5 types of human threats to data security, which can be made by current employees, former employees, and hackers. Now you should remember these. So, threats from our humans. Threats from employees who make honest mistakes, just human errors. Threats from employees who exploit their access to data. Threats from employees who use their access to data for malice or financial gain. Threats from external individuals who attempt to access data or steal hardware or other equipment. And last, threats from angry employees or others who attack the information systems of the covered entity. Threats due to human error are not intentional and result from mistakes or misunderstandings. Examples of human errors are cutting electricity to a building when digging, destroying the wrong disk, loading data on an internet server by accident, and entering the wrong configuration setting. Conversely, some threats are classified as intentional, including intentional deletion or alteration of data, infecting the information system with viruses, and using data to steal a patient's identity. External threats can be caused by people outside of the covered entity who attempt to gain unauthorized access. External threats also include natural disasters such as floods, tornadoes, and hurricanes, which may cause damage to the covered entity that destroys the system or temporarily disables access to the system. The goals of the HIPAA security rule are to ensure the confidentiality, integrity, and availability of the EPHI. Confidentiality means providing access to EPHI to only those who need it. Integrity is ensuring that data is not altered, either during transmission across a network or during storage. Integrity is discussed later in this chapter. EPHI must be available when needed for patient care and other users. Another important term is accessibility, which is ensuring that EPHI is available to the authorized users when it is needed. The security rule is designed to ensure that EPHI remains confidential and is protected from unauthorized disclosure, alteration, or destruction. The security rule utilizes administrative, physical, and technical safeguards to protect electronic personal health information. Administrative safeguards are people-focused and include requirements such as training, policies, and assignment of an individual responsible for security. Physical safeguards are mechanisms in place to protect hardware, software, and data. The physical safeguards should protect EPHI from fire, flooding, and unauthorized access to hardware, theft, and other hazards. And technical safeguards use technology to protect data and to control access to the data. Administrative, physical, and technical safeguards are broken down into implementation specifications and standards. The standards tell the covered entity what must be done, whereas implementation specifications provide directions to help the covered entity comply with the standards. Each standard is identified as required or addressable. Required standards must be implemented by all covered entities to protect electronic health PHI. Addressable standards must be evaluated by the entity to determine whether or not the standard is reasonable and appropriate. If the standard is reasonable and appropriate, then the covered entity must implement the standard. If it is not, then the CE has the flexibility to identify an equivalent method of accomplishing the same objective. Alright, so let's talk about our administrative safeguards. So, first of all, we're going to talk about the security management process. And this is going to include risk analysis, risk management, sanction policy, and information system activity review. Alright, so let's go back to our definition of administrative safeguards. We're still on 223, middle of the page. The security rule defines administrative safeguards as administrative actions and policies and procedures to manage the selection, development, implementation, and maintenance of security measures to protect electronic protected health information and to manage the conduct of the covered entity's workforce in relation to the protection of that information. All right, moving over to page 224, we're going to start with risk analysis. Risk analysis is the process of identifying possible security threats to the covered entity's data and identifying which risks should be promptly addressed and which are lower in priority. The risk analysis process requires the covered entity to bring staff from across the covered entity together to identify the data that must be protected. The risk analysis includes estimating the potential cost associated with security breaches and how much it would cost to develop safeguards to prevent these incidents. This analysis must include the risk to data confidentiality and the integrity and the availability of the EPHI it controls. To accomplish this, the team has to identify the threats to and vulnerabilities of the covered entity. All right, dropping down. Addressing the threats and vulnerabilities identified during the risk analysis help prevent failure of information systems. While all information system failures are serious, some have a greater impact on the covered entity than others. For example, failure of the patient satisfaction database will not be as critical as the failure of the EHR. If the patient satisfaction system is not working for a week, the data entry will be backlogged and the reports may be delayed, but the patient care goes on unimpeded. With the EHR, the patient's test results, allergies, past medical history, and the other information may not be available, which severely impacts patient care. So during our risk analysis, we are looking at impacts of losing one or more systems owing to malware, sabotage, hardware failure, breach of privacy, and other failure of the covered entity. And risk analysis also has to look for those natural disaster threats, such as floods, fires, tornadoes, hurricanes, even errors in data entry, viruses, and unauthorized access. So that's where all this risk management comes in, the risk analysis. Where are you vulnerable? Where can you be hurt? And how do you go about protecting yourself? All right, moving to risk management over on 225. Risk management is a comprehensive program of activities intended to minimize the potential for injuries to occur in a covered entity and to anticipate and respond to ensuring liabilities for those injuries that do occur. There must be processes in place to identify, evaluate, and control risk. The first step in risk management is the development of a risk management plan. This plan sets the priority for the implementation of the security measure identified in the security assessment. The plan should include a description of the risk, the security measures to be established, and an implementation plan for the security measures, including dates, resources needed, and ongoing maintenance required. Risk assessment and risk management are not one-time events, but rather ongoing processes. All right, moving down to sanction policy. Each covered entity must develop a sanction policy that addresses how employees will be penalized for failing to follow security policies and procedures. HIPAA does not require specific employee penalties, but requires the covered entity to determine how breaches and other violations should be handled. Employees should be notified of the policies and procedures and the penalties that come with the violations. They should also sign an acknowledgement of the security requirements to show that they understand the violations may result in disciplinary actions that could include termination of employment. Covered entities are required to conduct an information systems activity review, which monitors for the inappropriate use or disclosure of EPHI. HIPAA does not mandate the frequency of this review, nor the way this review is to be conducted. These reviews should include logs, access, and incident reporting. The CE should monitor audit logs, the incident log, and other internal and external documentation to identify all successful and unsuccessful attempts to access EPHI. All right, moving down to assigned security responsibility. This is where we're going to set our CSO, our Chief Security Officer. So the security rule mandates an individual to be in charge of the security program for the covered entity. HIPAA calls the individual a security official. However, this position is frequently called Chief Security Officer by the covered entities. This person's going to be responsible for developing the security goals and objectives for the covered entity, determining how the goals and objectives will be met, advising administration regarding information security, determining reporting procedures, conducting adequate risk assessment and determining the appropriate level of risk acceptance, and developing and monitoring the overall security program. The CSO works with others who assist in managing the covered entity security program. This individual must have a strong understanding of both technology and the business practices of the covered entity. All right, moving to workforce security. Policies and procedures should be in place to ensure that members of the workforce have an appropriate access to EPHI for their jobs. Information access management involves implementing policies and procedures to determine which employees have access to what information. One of the ways a healthcare clearinghouse can accomplish this is to isolate PHI from the rest of the clearinghouse information. Some healthcare clearinghouses are owned and operated by large corporations that conduct business in many different industries. To protect the ePHI, it must be completely separated from the non-health clearinghouse segments of the business. Additionally, each covered entity workforce member must be given access to data and systems functionality, such as accessing the EHR, and then it must be specified that what the user can do in the EHR, such as accessing whether or not a patient has an allergy. The covered entity must have a workforce clearance procedure. The workforce clearance procedure ensures that each member of the workforce's level of access is appropriate. The workforce includes all employees, students, volunteers, members of the board of directors, and others, paid or unpaid, who perform services for the covered entity. The access determination should be based on the risk analysis and each employee's job description. There must be a termination process to eliminate access to the information systems by a member of the workforce when that person's employment with the covered entity ends, either through resignation or through termination. The termination process should also include review for job appropriate access levels to include more or less access to ePHI, and the individual's role in the covered entity changes. All workforce members, including administration, board of directors, custodial staff, students, and volunteers, must receive security awareness training, which educates covered entity employees about the CE's security policies and procedures. Basic training should cover general security policies, physical and workstation security, password management, importance of logging out, and other issues. Many workforce members will require additional security training appropriate to their job functions. For example, management staff will need training on monitoring procedures and security system assessment. HIPAA does not mandate the format that the training takes, but a recommendation is to include it in new employee orientation. Face-to-face training classes should be supported with periodic security reminders, which could take many formats, including screensavers, periodic emails, articles or statements in an employee newsletter, and notices posted in public areas. HIPAA requires the documentation of training, including the following, and it must be maintained for 6 years: sign-in sheets, handouts, email messages, and training database identifying training and actions taken. Training should be ongoing and provided whenever there are changes to policies and procedures or to areas related to security. All right, moving down to managing a security incident. No matter how hard a covered entity strives to eliminate security incidents, they will still occur. The security rule defines a security incident as the attempted or successful unauthorized access, use, disclosure, modification, or destruction of information or interference with system operations in an information system. Because this definition is broad, the covered entity should define a security incident for itself. The security incidents should include both information technology incidents and physical security incidents. Examples include someone impersonating an information technology technician asking for a password, a former employee using old identification and password to access each PHI, virus attack that destroyed current files, audit trail with evidence that someone misused someone else's password, corrupt data tapes with no ability to restore archived data, physical break-in with ePHI copied or stolen, PHI posted on the internet from a web portal, misdirected email with ePHI, a terminated employee keeping copies of records with PHI, and CDs containing ePHI found discarded without physical destruction. ARA requires CEs to actively identify and report security incidents. The security incident policies and procedures should identify how the incidents will be identified and to whom they should be reported. Security incidents through the CE should be reported to someone in a centralized role, such as the CSO, and must be addressed quickly because inaction could allow the incident to worsen, such as in the case of a virus. Policies and procedures informed by the severity of the security incident should define how the CE will respond. If the incident suggests criminal activity or compromises the safety of the individual, the local law enforcement agency should be contacted. All right, so let's talk about a couple of these definitions here. So let's talk about forensics. Forensics is the process used to gather intact and validated evidence, and is the process that should be used to gather evidence of a security incident. The steps in forensics include documentation of the investigation conducted, protection and preservation of any evidence found, the logs reviewed and reports, documentation of the chain of custody, and use of an exact copy of media in the investigation. The investigation may require hardware to be confiscated and stored in a secured location, network logs to be printed, data to be backed up, and other investigative steps. Failure to protect data may result in the intentional or unintentional destruction of evidence. Now, spoliation, which should sound familiar from law and ethics, is the intentional destruction, mutilation, alteration, or concealment of evidence, or alteration of evidence. Dropping down. Once a security incident is identified, the CE must mitigate its harmful effects and document both the incident and the outcome. Mitigation is the process of attempting to reduce or eliminate harmful effects of the breach. All right, dropping down to security events. Security events are poor security practices that have not led to harm, whereas security incidents have resulted in harm or significant risk of harm. Security events may be employee mistakes, many of which result in noncompliance with the covered entity's security policies that did not result in disclosure of EPHI. Examples of security events include sharing login information with another employee, password reminder visible at workstation, so if you write your password on a sticky note and you leave it at your desk. Computer system left logged on and unattended, so you're logged into the EHR and you walk away from your desk and leave it up and open. System access to patient data down with only paper copies of encounter forms, unencrypted or otherwise unsecured email of PHI, and maintenance personnel fixing equipment with PHI without supervision by the covered entity's workforce. All right, moving over to 228. I'm going to talk about ongoing security procedure evaluation. Implementation of the security safeguards is not enough to comply with the HIPAA security regulations. Covered entities must also critique its security program through ongoing monitoring and evaluation to identify areas for improvement. The evaluation must include both technical and non-technical processes. Technical processes are those that use technology such as encryption, access controls, firewalls, audit trails, and other technical tools. Non-technical processes are the security measures that do not require technology, including policies and procedures, training, evaluations, monitoring, and other administrative responsibilities. All right, moving down to contingency and business continuity plan. When information systems are down, covered entities must have a plan in place to continue business despite being unable to retrieve information, place orders, or perform other key tasks. This plan is called a business continuity plan. This business continuity plan is a program that incorporates policies and procedures for continuing business operations during a computer system shutdown. It should include when the plan should be implemented, who initiates the plan, which manual processes are to be used, what forms are needed, and how to update the database once the system is again operational, and more. A contingency plan is made up of policies and procedures that identify how a covered entity will react in the event of an information system emergency, such as a power failure, a natural disaster, a hacker, malware, or a system failure. A covered entity can take steps to reduce the risk of the EHR or other critical patient care systems from being down or failing, but it cannot eliminate the possibility. Therefore, it is important to back up data so that if the system fails, the data can be recreated from backups. The contingency plan should include a data backup plan. The backup plan should address frequency of backups, where the backup data are stored, testing the backups, and more. The data backup plan should include all critical sources of information, such as the EHR and the clinical information systems. To help prevent failures due to hardware failure, redundancy is needed. Redundancy is duplication of data, hardware, cables, or other hardware components of the information system. As data are entered, it is also saved into a second computer server, creating a way to access an operational information system with little to no downtime. And there may be a time when disaster strikes and the CE loses data because of flood, fire, tornado, hardware failure, or other failures. The covered entity must have plans in place to get the information system working again and then to update it with all activities that occurred during the downtime. The emergency mode operation plan encompasses procedures necessary to keep the critical business process of the covered entity in place during information system downtime. Manual processes such as paper laboratory slips, microfilm of the master patient index, and health record forms must be available in the event that the information system is down. The contingency plan must be tested periodically and revised as areas needing improvement are identified. All right, moving down to data recovery. When the information systems are again functional, data recovery must occur. Data recovery in the process of recouping any data that has been lost from the information system crash, as well as the data that was obtained during the downtime. Data backups may be used to bring the information system back to its original state. Data captured during downtime must be entered into the information system to bring it up to date. Lost data should be recoverable from backup servers or other storage media. Depending on the time since the last backup, little or no data may be lost. The covered entity must have current backups of the database to be able to recreate the data. Information systems should have a utility to restore data from the backup server or other storage media onto the database. This process should be tested periodically to ensure that the utility is working appropriately. All right, we're going to cut this lecture off here, and we're going to pick up with the last 3 sections in the next lecture. So happy reading, happy studying. Again, cover all of the information in the chapter. I just hit the highlights.